And welcome to the Texas Talks podcast. I'm your host, Brad Swale. Today is another in the Future of Texas podcast series in conjunction with Texas 2036, where we explore the decisions shaping our state between now and the bicentennial in 2036. I'm Brad Swale, and today I'm joined with Avik Roy, the co-founder and chairman of FreeOp, and Charles Miller, the director of health and economic mobility policy at Texas 2036. Today's episode is about an issue that hits closer to home than almost anything we've covered in this series: the cost of healthcare in Texas. The numbers are staggering, the politics are shifting, and there's actually something a motivated state can do about it. That's what we're here to explore. A quick note on timing: we recorded this conversation at the same time as the new House Select Committee on Healthcare Affordability was holding its very first public hearings. So if you're listening when this drops on May 5th, the committee met just last week. The conversation you're about to hear is as timely as it gets. So, Avik Roy and Charles Miller, thank you both so much for being here. I really appreciate it.
Thanks, Brad.
Thanks. Thrilled to be here.
Yeah, it's a pleasure. So, I guess we'll start with you, Charles. Why should a Texas CEO or state policymaker today, now in this moment, care about healthcare?
It's a bottom line issue. The cost of health insurance to insure a family on an employer-sponsored plan is $27,000 a year. And that's eating into wage growth. That's eating into their ability to hire new employees. And it's ultimately eating into their ability to be a more productive and vibrant company. That cost is borne by the employee. It is also borne in the opportunity cost for that employer. And we just spend too much on healthcare as a country.
Yeah. I'm going to move your microphone just a little bit closer to you.
Sure.
You're fine. Yeah, I think, just as an average Texan, healthcare is crazy expensive, and I don't remember a time when it was cheap. When it was cheap, when I was younger, my parents were paying for it. I didn't really know any better, but I think we spend roughly $5.3 trillion a year on healthcare in the United States, and that doesn't seem to be really slowing down. Avik, can you chime in on that as well? Why is now the important time to be focusing on healthcare and trying to bring those prices down?
Well, as you said in your introduction, it's not like there's ever an unimportant time to talk about healthcare because it's such a big component, the largest component outside of housing for that in terms of things that are taken out of people's household income. And just to drive it home, we Texans are very proud of how economically competitive our state is in general, how we attract entrepreneurs from all over the world, all over the country to move to Texas, start businesses. The Texas economy is growing, it's drawing people in. We have a relatively low cost of living on many fronts, but not healthcare. So just to take the comparison that Texas politicians like to use, which is California, if you look at the out-of-pocket expenditures for healthcare, which means what share of your premium are you paying, not your employer, what's your deductible, what are your copays, when you add that up, for the average Texas family, it's about $10,000 a year. For the average Californian family today, it's about $8,500 a year. So we're above the national average. California is actually slightly below the national average. And so we've gotten to a point, and just to put another fine point on it, the average Texas household's tax burden is about $6,000 or $6,500 a year. So just to reiterate, the average Texas household is out, their out-of-pocket exposure, not just counting the total cost of healthcare, but their out-of-pocket exposure for healthcare costs is about $10,000 a year. Their average tax burden is about $6,500 a year. So Texas politicians love to talk about cutting people's taxes. And look, I love a tax cut as much as the next guy. I really do. And I'm grateful to our politicians who cut my taxes. But they would actually be making much more of a difference in my life if they could get healthcare costs to stop growing so rapidly, because that is eating into and overwhelming all of the tax savings that Texas leaders are achieving each legislative session.
And you asked why now, and I think this data is probably informing what we're seeing in the polling results. So we conducted a poll of voters back last fall, and the number one issue that voters said they wanted their candidates to focus on was healthcare affordability. And that was more important than property taxes, that was more important than homeowners insurance, that was more important than the disaster relief and water infrastructure. These are the issues that have been taking up so much time at the Capitol. But health affordability is higher on their mind, and it's probably because it's costing more.
Just to chime in, I'm sorry, that's surprising that it's above property taxes. Every time I've talked to a legislator on the show, it's been, they communicate to me that their constituents always, doesn't matter what they say online about something totally irrelevant, if they tweet something out, someone's inevitably going to say, what are you doing about property taxes? So it's amazing that this ranks up higher than that.
It was that high last fall. The KFF, Kaiser Family Foundation, just put out a poll of adults in America, and the cost of healthcare, the affordability issue around healthcare, was a bigger concern to them than the ongoing affordability issues around gasoline. And we know how high gas is right now.
One caveat we can put in terms of who's concerned about it.
Yeah.
Like if you're over 65 and you're on Medicare, your exposure to the rising cost of healthcare is more limited than if you're under 65 and you're getting health insurance through your employer. So it depends on which age group and what income bracket you're talking to in terms of who's really more directly exposed to the high cost of healthcare. But again, if you're concerned about the growth of the Texas economy, you want more businesses to move here, you want more talented people to live here, this is the biggest barrier.
Yeah. So, I mean, the numbers that I have, it's the family coverage, employee-sponsored coverage right now, it's up 53% since 2016. It's about 1/3 of the median Texas household income. And, I mean, 53% increase since 2016, that's 10 years. And we're talking about, this is the future of Texas. We're talking about what do we do from between now and the bicentennial, 10 years from now. I'm wondering, how did we get this 53% increase in this past 10 years, and what can we do to stop the next 53% increase in the next 10 years?
Well, there's a national component to this, and there's a state-based component to this. I mean, and healthcare is a big problem nationally, as Charlie has mentioned. But I want to highlight a couple of things that are Texas-specific, and that is we have a political culture and a policy culture in Texas where we are extremely deferential to the big hospital systems, to specialist physicians. They're very powerful constituencies. And just to give an example, a couple legislative sessions ago, the Texas legislature passed a bill to tackle surprise billing. Surprise billing is the phenomenon where you go to the hospital, you're in the emergency room, a doctor sees you who's out of network with your insurance, but you had no idea because you were just sitting there, you were unconscious.
I had a broken arm or whatever, yeah.
Yeah, and you get a $100,000 bill, and this is a big deal around the country. Texas passed a version of surprise billing reform that they were very proud of in the legislature, but the end result of that legislation was to actually drive up healthcare costs even more, because basically what they did is they said, we're going to require insurers to basically pay this inflated price for these surprise bills. It actually incentivized more physicians and more hospitals to charge higher prices than they were before. And that's the kind of thing we see in Texas a lot, is that efforts at reform are actually so aggressively influenced by the existing healthcare players that the end result is higher healthcare costs, not lower healthcare costs.
This is an example of, I like to say, the road to unaffordability was paved with good intentions, and these efforts, both at the Texas state level as well as at the national level, were designed to solve a problem that patients were having, which is they had no control over what these bills were or to select their provider, and so it was to protect them against these things that they had no ability to control. But the devil's in the details, and when the legislature considered how to figure out what a fair price was, they built a system that had misaligned incentives and perverse incentives. One of the factors that is used by the arbitrator to decide what the amount is that the provider gets is the provider's own billed charges, which means that a provider who is basically trying to set this up can use a billed charge amount that they have entire control over. It is not tethered to any market level.
It's like a list price rather than a real price. It's like whatever you want to put on the sticker.
Yeah.
They have complete control over it. It's not related to any market reality. And by raising that, they're now able to increase the amount that they get from the arbitrator, because that's one of the factors that's included. It is a well-intentioned program that had poor system design.
Well, maybe I'm a little more cynical, Charlie, but I sort of feel like that was built into the system because the hospital and the side that wanted costs to be higher put those in intentionally. So it wasn't like this is an unintended consequence. This was part of the design for a reason.
I don't disagree with you that the special interests were absolutely pushing for that, and sometimes our policymakers are aware of this, and sometimes they're not aware of this. This is why it's so important to get into those details.
Well, Avik, so we've touched. I think we've sort of touched around the edges of this a little bit throughout the conversation so far, albeit so short. We still have much more to go. But a lot of people assume that it's either a government problem or a free market problem, and I'm wondering how you feel about that. Is it an either or? Is it a both? Is it neither?
Yeah, that's a great question, actually, because there's a huge misconception in the American healthcare debate that America has a free market healthcare system, and that's why it's so expensive. If we just had a single payer system like the UK or Canada, then healthcare would be cheaper.
Yeah.
Now, it is true that healthcare is less expensive in the UK and Canada because they have price controls, they regulate the utilization of expensive services. That's how they control costs, and they do compared to us. But that's not to say that we have a free market healthcare system. We actually have the worst of both worlds because we have a heavily subsidized system, and yet we don't regulate or ration care or control prices. So a free market system would say, don't subsidize it so fully that nobody has an agency to reduce prices. Because like in a consumer system, like when you shop for a laptop or a car or an apartment, you're very price sensitive. You shop for a good deal. You shop for good values. But when it comes to insurance, for the vast majority of Americans, you're not actually shopping for the insurance. Somebody is buying it for you. Either your employer is buying it for you or the government's buying for you. And that was the original sin of the U.S. healthcare system, is that as an outgrowth of wage and price controls in World War II, we decided to exclude from taxation the value of insurance that was acquired for you by your employer, but not insurance you buy on your own. Only insurance if you got it from your employer. And that distortion in the tax code meant that employers basically, if I'm your employer and I pay you $100 in salary, about a third of that goes to the government on average. If I give you $100 in health insurance, you get $100 of health insurance. So in other words, you get a 50% bonus if I route your money through health insurance rather than actually just giving it to you and putting it in your pocket and you spending it how you want. And over 80 years, that system has meant that more and more things get defined as health care, more and more things get covered by health insurance. And a lot of us just psychologically think of healthcare as kind of the open bar. Like if I'm at an open bar, I'm not ordering the Bud Light. I'm ordering a nice glass of wine or a single malt scotch or something like that. And it may seem to trivialize healthcare to say that we behave that way with healthcare, but the economic incentives are the same. When we go to the doctor, when we go to the hospital, we don't ask what it costs. We just assume our insurance covers it. If you're a doctor and you go to medical school, there's no class you get taught in medical school about how to care about what this costs the patient. You're just told, do the thing that's the best clinical outcome, irrespective of cost. So nobody in the system is trained to care about how much this costs the patient. And that's the direct result of a system in which we've said, you, the consumer, have no agency in how to save money in healthcare because you don't think you're spending your own money, even though you actually are.
Yeah. I mean, as an extremely young man, I would like that $100 in healthcare. I would rather have that $100 in salary.
Right.
I can choose to do something else with it. So, Charles, I'm curious how you feel about that. How do you feel about that dynamic between, is it government? Is it a government problem, free market problem? Where do you fall?
We view it as a little bit of a synthesis, and we wouldn't say that the ideal or end state is a free market. We would focus on it being a competitive or a healthy market. And Avik's talking a lot about making sure that everyone's got the right incentives. And a well-structured market aligns those incentives so that when people are pursuing their own self-interest, they are working toward a greater good. That is how a market is supposed to function. And when we think about what's needed for that market to function, there's really three big components. And so it needs to be informed. People need to have the right information to know what it is that they're purchasing. They need to know what the price is of something before they purchase it, and they need to know what the quality is of something before they purchase it, so they can make that value decision. And there's always a trade-off between that price and that quality there. It needs to be competitive. You need to have choices for a market to work. If you just know the price and the quality of something, but you only have one choice, most likely you only know how badly you're getting hosed. And so you need to have that availability to choose something else for that competition, those competitive market discipline forces to work. And then the last thing is the hardest, and this is especially hard in healthcare, but it's about making sure that we have aligned incentives. And so when we have a third-party payer system, which is what Avik's been talking about, insurance pays for so much of the care in this country, and that is the person that is receiving the service is not the person that's paying for the service, so somebody else is making a decision on your behalf. If they don't have the same interests that you do, then we're not going to get a good decision. So a big part of this is about trying to align those decisions, align those incentives so that everybody is working towards the end state, which is a good value for the patient. And the complexity adds to this.
I was just going to add one thing, which is most people know that America has the most expensive healthcare system in the world. What a lot of people don't know is that the America also has the most heavily subsidized healthcare system in the world. Government subsidies per capita in the U.S. are by far the largest in the world. It's about $9,000 per person, per man, woman, and child in the U.S. And the next highest country is like Luxembourg at like $6,000. And most countries are way below that. So, some people say, well, the answer to healthcare is let's just subsidize it more. No, we actually subsidize it more than enough to pay for everyone to have health insurance. The problem is that the healthcare in America is so expensive that subsidizing it is also extremely expensive. And that goes to this point that the way we subsidize healthcare, the way we try to support care and coverage is extremely badly designed.
So here's an example where increased subsidies combine with maybe well-intentioned but perverse incentives to create a problem where prices go higher. When the Affordable Care Act was passed, it included this thing called the medical loss ratio. And this says that insurers have to spend a certain amount of the premium dollars that they bring in on actual health care. And in the individual market, it's 80% that they have to
85%.
spend. 85% that they have to spend. This now means, from an insurer's perspective, that they have to make all of their profit on that 15%. So if your profit is limited to 15% of your premiums, the easiest way to make your profit go up is for your premiums to go up. By itself, we might think that competition could constrain this, but when we also subsidize the marketplace, and something like 85 to 95% of enrollees in the individual marketplace in Texas are subsidized, the insurer now really doesn't have any incentive to constrain the prices that they're paying for services. Their role in this system is supposed to be to keep prices down. But now we have a system where they make more money if premiums go up, and the subsidies make nobody price sensitive on premiums. We get inflated prices.
I mean, it sounds like there's so much. I mean, it sounds like transparency is an issue. It sounds like price. I mean, I don't want to say price control needs to be implemented necessarily, but people don't really know why something, as you've sort of alluded to before, if I don't know how much something costs, how am I supposed to make a decision? If I'm laying in the hospital bed with a heart attack, yeah, just do whatever you need to do. It would be nice to know how much it's going to cost. But also, it's hard to know. I've never talked to a doctor once and them told me, for any reason, just a regular checkup or a hospital, this is about how much it's going to cost.
Well, one of the models that we like to talk about at my think tank, the Foundation for Research on Equal Opportunity, is Switzerland. We actually do a survey every year called the World Index of Healthcare Innovation, where we compare the 32 wealthiest countries in the world by GDP per capita that have a population over 5 million. And the country that is ranked first every year on quality, choice, science and technology, and fiscal sustainability is Switzerland. And Switzerland has a really interesting system. It's basically, you could say, Medicare Advantage for all, or Obamacare for all. And what do I mean when I say that? I say that there are no government insurers in Switzerland. There's no Medicare or Medicaid or a single payer kind of thing. It's all private insurers. And like Obamacare, the Affordable Care Act, there are subsidies that phase out as your income goes up. So if you're really low income, your premium might be completely covered in Switzerland, but as you become wealthier, your subsidy is much less, if not zeroed out. But there's dozens of insurers competing for every Swiss citizen's or Swiss resident's business. And even though there is regulation as to how the insurance is designed and what you have to offer, the competition does work, and the competition, because people are price sensitive. And so even if all these regulations are in there, there's enough room for competition in the Swiss system that there's robust agency among people to say, I'm going to shop for the plan that does the best job of driving a hard bargain with the hospitals and the doctors and the drug companies. And on the back end, Switzerland does a really nice job of saying, okay, if you are a regional monopoly as a hospital or a drug company or something like that, we're going to have a more robust arbitration-style process for negotiating the prices the prices that insurers pay for your products. And so they tackle the monopoly power of hospitals and drugs really intelligently in Switzerland. I know that Charlie has done a lot of work on this. We have as well at the federal level. This is one of the most important challenges, is that choice and competition are really important and really valuable and work really well, I think, especially if you're choosing your own insurance plan, not getting it from your insurer. But some of the things that you have to still address is it's great if you have a choice of 20 insurance plans, but if you can only go to one hospital system that dominates your metropolitan area to get care, then that hospital system is going to charge whatever it wants to every insurer because the insurer has no bargaining power to take you to a lower cost provider. So we have to do more to improve the level of competition for all these healthcare services. And just to give an example, a bunch of years ago, I tore my Achilles and had to get it surgically repaired. And the surgeon charged me $6,000 to fix my Achilles. The anesthesiologist charged me $9,000 for the anesthesia. Now you might think, wait, what? Shouldn't the surgeon get paid more than the anesthesiologist?
Well, it's good that you didn't feel it.
Now, of course, the anesthesiologist will say, hey, we're very skilled and we're doing very important. Yes, I'm not telling you, don't make me feel horrible. But I think most people would say what the surgeon did to fix my Achilles is probably more important than the person who twists the dials on the anesthetic. And yet the anesthesiologists charge more. Why? Because there's one group of anesthesiologists that controls the entire Austin market where I live. And they basically are able to charge whatever they want. Insurers have no choice but to pay it. So they have monopoly power over the anesthesia market in Austin. And these are the kinds of things that I bring up because Texas, there's certain things about healthcare like the tax exclusion for employer-sponsored insurance. That's something that you got to fix at the federal level. Congress has to fix that. But the monopoly power in Texas of these various players, the Texas legislature could take that on, and it hasn't to date.
So I would say, I think you and I both come at this from an approach of how can we make markets work? And I think that there's maybe some confusion sometimes that occurs over what is the role of, say, antitrust policy in making markets function. One of the approaches that I was really struck by is, what was it, the Hospital Choice and Competition Act?
Hospital Competition Act,
Hospital Competition Act. And this gets at maybe how do you both restore competition if we're kind of teetering on the edge, and then what is a legitimate state response when there is no functional competition? And just wanted to hear you talk about that aspect and how that can align with a market-looking, market-leaning philosophy.
Yeah, so we developed an idea a few years ago that's been introduced in Congress as the Hospital Competition Act. Its main champion is a senator from Indiana named Jim Banks. And basically the idea is we've had an enormous amount of consolidation of hospitals. It used to be every hospital was kind of a standalone entity.
Sure.
And then over time, hospitals started to merge and become regional monopolies because they wanted to have this bargaining power against the insurers who were trying to drive prices down. And over time, this got worse and worse and worse. And sometimes the Federal Trade Commission or the Department of Justice or a local antitrust official would try to block these mergers and say, hey, if these two hospitals get together, they'll raise prices because they'll use their market power to do that. And during the 80s and 90s, most of those cases that were brought before judges, the judges sided with the hospitals. They said, well, there's not a lot of evidence in the academic literature that these things raise prices. And, the hospital CEOs...
And to be clear, that has since changed. There's now robust academic evidence.
But at that time, there wasn't. And 3/4 of hospitals are nonprofit, so there's this kind of halo effect of, oh, you're a tax-exempt institution, you're 501c3, you're a nonprofit, therefore you must be, an angelic and not doing anything terrible.
It is nonprofit after all.
Right,
Yeah.
right. And but in fact, what the research now shows, and there's more evidence about this, is that nonprofit hospitals, so-called nonprofit hospitals, let's call them tax-exempt hospitals, behave just as economically as a for-profit hospital in terms of looking out for themselves, wanting to make as much money as they can. And yes, they don't pay income taxes on it, but that doesn't change their incentive to make money. And so now that there's much more research showing that a hospital consolidation raises prices, people want to do something about it. The problem is, if you're the Federal Trade Commission or one of these antitrust regulators, you get a little scared because like, okay, so now things are so consolidated, and you have these giant networks of hospitals that are consolidated. If I break up these hospitals, what if some of them close down? And I, as an antitrust regulator, we're now responsible for some community losing its local hospital because it closed down because it's not part of this giant system. So people are very scared to reform the system because they're worried that there would be some unintended effects. And so what we propose to deal with that, which is say, you can block the mergers of the future, and that's fine, but because it's already so heavily consolidated, it doesn't solve the problem. What do you do about the consolidation that's already happened, like this anesthesia group I was mentioning? And so what we've proposed is there are measures of market consolidation that have been developed for many years by health economists and economists in general. Why don't we use those measures to say, if a market is very consolidated, we can tell that hospital system or that market, look, if you want to stay consolidated, that's fine, but we're going to require that you use Medicare Advantage prices, which are about a third of the prices that people charge in the regular commercial market for people who get insurance through their employer. If you want to break up, you can do that, and then we won't. You can charge whatever you want. But if you stay a monopoly, if you stay consolidated, you have to accept Medicare Advantage prices. And the reason we do that is kind of like auto antitrust. So instead of putting it in the regulator's hands, let's say Charles runs a hospital across town and I run a different hospital. We know right away whether the merger will make us money or not. If we want to merge, we can say, okay, will we make more money if we're charging Medicare rates?
Yeah.
Or will we make more money if we stay independent and compete with each other? We can build a spreadsheet so we don't have to wait for a judge to decide what's going on. We don't have to wait for the Department of Justice or the Federal Trade Commission to weigh in. And so it actually creates a lot of regulatory certainty for the healthcare industry to be able to say, okay, we know what's going to happen, and we can decide, are we going to be better off as independents competing with one another, or are we going to be better as a consolidated system? And our bet is that most hospitals will take the first bet. They'll say, you know what? Because we're charging so much more to people in the non-Medicare market, the non-elderly market for people who get insurance through their employer, I'd rather stick with that system instead of what they do now, which is merge to take advantage of the monopoly power. We basically take that away from them.
I heard Governor Braun, then I think Senator Braun described this basically is, if you want to act like a utility, then we will regulate you like a utility. If you want to act like you're in a competitive marketplace, then we'll treat you as such.
Exactly.
And it really gives that choice and that power to the market actor rather than having a heavier hand of government coming in and making that decision for them.
Because the regulators are very sporadic, right? They'll take on one merger here or one merger there, and they don't have the staff to take the entire national problem on. And that's why it got so bad, is that these mergers are local, right?
Yep.
It's 2 hospitals in Cincinnati or 2 hospitals in Houston. And that's very hard for a federal agency to do anything about. And the challenge at the state level, in most states, it's the attorney general who has the authority to take this on. But, every attorney general that I've ever met looks in the mirror and sees a future governor or senator, and they want those hospital CEOs on their side when they run for higher office. And so they're very afraid to take on the big hospitals in their state. And so we often rely on the federal government to actually come in and fight these local mergers, and they won't do it because it's just not big enough for them. They're too busy dealing with Time Warner merging with Comcast or Continental Airlines merging with United Airlines, these big national mergers that affect, tens of millions of consumers. A local hospital merger is just not something they have the time to deal with. And so that there's a kind of a gap in the competition regulation space.
Well, and the other thing is that the federal government only looks at things above a certain size. There is a statutory floor below which they do not even evaluate this. And so some clever companies have figured out, well, if we structure our acquisitions over time in these series of smaller buy-ups and acquisitions, we can basically evade federal review of any of these and acquire that market power slowly and over time.
Yeah, it's called the Hart-Scott-Rodino threshold for people who want to Google it later, and it's if the merger is above a certain percentage of GDP, then regulators can kick in, and if it's not, they basically don't have a lot of space to do anything. And so, actually, one of the reforms we proposed is to change that, to actually look at local GDP as opposed to national GDP. So, if a merger might dominate the GDP of, say, the Houston metropolitan area or the Dallas-Fort Worth Metroplex, you can look at it that way.
So we've talked a lot about, Avik, you've talked about Switzerland, and Charles, and both of you really have talked about the sort of the problem on the national scale, the employers paying for the healthcare, all of that stuff. And, I'd like to sort of hone in a lot on Texas. And I guess I'll start with you, Charles. What has Texas done recently? And then let's talk about what Texas needs to do the 90th Texas legislature is right around the corner. I say that it's in January. That feels like right around the corner in legislature terms. But what do we need to start looking at?
So Texas is actually, I talked earlier about the three conditions you need for a healthy market. It needs to be informed, you need transparency, so you need competition, and you need the aligned incentives. I would say the bulk of the work that has been done to date has been around transparency. There's been a lot of efforts around making prices more transparent and more available, as well as we recently funded our all-payer claims database, which is this giant warehouse of data where all these claims go in, and nerdy researchers like us can go take a look at it and learn more about what services, what people are paying for it, and where potential value is. So that's very good. That's progress. The other thing that's been done is a major effort at the state to go after what we call anti-competitive contracting practices. And when we were talking earlier about hospital mergers and maybe the Hospital Competition Act, this is a phenomenon that we call horizontal integration or consolidation, and that's where a like type of provider buys out another like type of provider. So the anesthesiologists roll up or the hospitals buy each other out. There's another type of consolidation that occurs. It's called vertical consolidation. And this is when, say, a large hospital system starts buying up specialty practitioners, primary care physicians, and they try to have an entirely vertically integrated supply chain of the entire healthcare delivery system. We also see this on the insurer side. The largest employer of primary care physicians is a insurer, and it's United Health Group. They own the Optum Physician Group nationwide. We also see this with the drug supply chain. The problems that can arise here are if you have a vertically integrated system and have already created monopoly at one level of that supply chain, you can now leverage that monopoly to make the entire rest of your vertically integrated system non-competitive. What does that mean? That was a whole bunch of gobbledygook. All right, if you have a must-have hospital for an insurer, that hospital has to be in the network, and that hospital now also has a whole bunch of affiliated providers. The hospital could go to the insurer and say, if you want this hospital in your network, you have to include all of our other providers in your network, and you can't adjust the price. It doesn't matter what price our providers charge. It doesn't matter how good the quality of the care is. You have to include them in your network, and you have to put them at the highest tier. That is what we're talking about with vertical integration and anti-competitive contracting practices. The state has done some good work here. It's not perfect, but it's very good. And what they did is said it is illegal for a provider to put into their contract two types of clauses that are very important: anti-steering and anti-tiering. What they can't do is leverage that hospital to say, in the contract, the insurer is not allowed to drive people or incentivize people to go to lower priced, higher quality providers at the area where competition can still be. So that's a really good thing that the state has done. I would say that Texas's law is among the best on this that has happened nationwide. I really want to give credit and praise to the legislators who passed this, because it was hard to do. And as Avik has noted, there is a lot of money and power and effort fighting against that. This was a big step the state took. But there is more to do yet. We have not done anything like that in the drug pricing space or in the consolidated chains that occur in the drug delivery mechanism, for example. And there are all sorts of other, I would say, misaligned incentives and anti-competitive acts that are occurring that the state could start to weed out and go after and regulate.
So I agree with everything Charles said in terms of.
We'll just stop right there.
The most important thing the legislature can do to reduce the cost of healthcare is tackle these anti-competitive practices and the monopoly power that drives prices up. That's the most important thing they can do. I think there are two other things that are really interesting where the legislature doesn't have to do a ton, except to not get in the way of some innovative things that are happening and maybe facilitate them in certain ways. The first is, I mentioned that one of the big distortions in healthcare is the fact that most of us don't shop for our own insurance plans. We basically get it from the government or our employer, and we just say, okay, I work for this company. They've handed me a card that says I have Blue Cross or United or whatever it is, and you just hope it works. There's a new system called ICHRA that was established a few years ago by some regulatory reforms at the federal level. ICHRA stands for Individual Coverage Health Reimbursement Arrangement, ICHRA. And what ICHRAs allow you to do is, instead of your employer handing you that insurance card and being in charge of shopping for the insurance for you, the company can instead say, here's $5,000 or $7,000 or $3,000, whatever the number is. just as tax-free as the employer-sponsored insurance plan, but instead you go shop for your own plan rather than having the insurer choose the plan for you. And so that can be one way to introduce a little bit more price competition in health insurance, where, okay, the employer says, here's a certain amount of money. If you spend more than what I've given you, you have to pay the difference. And if you spend less, you pocket the savings.
Yeah.
So that really gives the employer, the worker, that sovereignty or that agency to shop for a plan that the worker likes and incentivizes the insurers to compete on price. So I think that's one area that's really interesting, and there's several Texas-based startups that are in this space. One based in Dallas is called Take Command Health. There are several others. So this is a space that's really promising, really interesting. Another one that I really like is kind of alternatives to health insurance. Now, most of us, we have this paradigm that everyone's got to have health insurance because you want to protect people against going bankrupt because of medical bills. But there's a really interesting company based in Austin that I'm actually on the board of called Crowd Health. And what Crowd Health does is they work outside the system of insurance, and they say everyone pays a membership fee to Crowd Health, and then voluntarily contributes to the healthcare costs of other people in the crowd, and they negotiate based on the cash prices for healthcare.
Yeah.
So Charles was mentioning earlier that there's all these incentives for inflation, where the insurer says, you know what, I'm going to, your bill for your knee surgery is $20,000. I'm going to pay $30,000 because I'll make more money off of that, right? So there's this massive inflation that occurs because insurers don't want to fight to lower prices. They actually have an incentive in certain ways to have higher prices. But when you pay cash, you can actually really negotiate a better price than what insurers have negotiated. And Crowd Health is showing that the cost of healthcare for their system, again, it's not insurance, so it's not for everybody, but for the people it serves, they're getting 1/2 to 1/4 of the costs that a normal employer-based insurance plan has. So that's a really interesting system that can serve a lot of people.
If I can jump in there, I think this is a really interesting avenue for the state. And Texas has passed a law to start to encourage some of this. It was
Right.
A couple sessions ago. This phenomenon where you can get a cheaper price by paying in cash than you could by using your insurance is a lot of folks have seen this happen, but they also frequently face this difficult choice. If they pay cash and don't use their insurance, it doesn't count towards their cost sharing, so they don't hit their deductible. What Texas did a couple of sessions ago is put into effect a rule that says if you go find a cheaper cash price, you can have that count towards your deductible. Now, there's room to improve it. It doesn't apply to prescription drugs right now. It's a little bit clunky to use administratively, but this was a good start that's designed to get at this phenomenon of how you can use price or cash prices. The other thing I'd say that we have been hearing more of is some providers are actually not allowing you to use a credit card if they have evidence that credit card was issued by your insurer, because they are seeing they're using the cash price loophole, as they would call it, and they're discriminating against that. I think that's something the legislature should take a look at and see if they can figure out how to avoid that kind of discrimination.
And another thing I'll add is, Charles was mentioning earlier the all payer claims database, which is a database of all the prices that insurers negotiate with doctors and hospitals and others. And ideally you have artificial intelligence knocking through all these data sets, and you can actually do a really good job of identifying optimal cash prices and who's doing a great job of negotiating good deals. And so price transparency, artificial intelligence, and the creativity of some of these homegrown startups that we have in Texas, I think those are some of the areas that show the most promise outside of the legislature doing what I'd like them to do.
Yeah.
I've got one extra area that I would be remiss if I didn't mention, and this is there's a lot of concern sometimes in the Texas legislature about how much do we want to go say to insurers, here's how you have to structure your business, and is that too heavy-handed as a regulator? But there is an area where the state has a huge impact on how insurance is designed and how the benefits are designed that everybody agrees is the state's role, and that is when the state is acting as the employer itself. And the state is the direct employer of 500,000 folks around and also runs the teacher benefit plan. Collectively, there's about 1.1 million people who get coverage that is directly controlled by the state. And the state, in its role as employer and benefit manager, can start enacting some of these innovative benefit designs to bring the price down. And because the state has the scale to do this, there will be spillover effects. We have seen in other states that when the state takes an active hand and does this, 75% of the benefits accrues to the commercial market as spillover effects.
Yeah.
So this is a really important area for the state to take a look at.
The best example of this in practice is, I believe, Montana, where this incredible woman, kind of a grandma type, basically went
Marilyn Bartlett, for those who want to go look
Marilyn
up, yeah.
Bartlett went to every hospital in Montana and said, for the state employees, I want to pay, I think it was like 130% of the Medicare price, so much lower than the traditional private sector price. And they fought her tooth and nail, but she won those battles with the help of labor unions, actually, that worked with her to achieve these lower costs. And they saved an enormous amount of money for those state workers, but also for the taxpayer, because the taxpayer's footing the bill for public employees. And a lot of that's public school teachers, university employees, and the like.
Yeah.
So we were talking about the APCD. We are right now, to help out our state employee benefit plans, using the APCD to look at all those claims and try to figure out what is the best way that they design that plan, what is the best price that should be paid, and hoping to have a report coming out on that later this year.
So we're getting pretty short on time here. So just real final question before I close out the show. What does it look like if we get this right in Texas in 2036? Is my healthcare going to be affordable? Is your healthcare, is the general Texans' healthcare going to be affordable? What do we need? What does it look like if we get this right? I'll let you start, Avik.
Well, listen, I mean, we can all dream of what an ideal healthcare system would look like,
Sure.
but I would say, assuming that Congress does nothing, which is always a good base case, and that it's up to us in Texas to actually try to tackle our own problems. And we're talking about 10 years from now. We're recording
Sure.
this in 2026. I think it would be pretty amazing if we could limit the growth of healthcare costs in Texas to consumer inflation, 2-3% a year. If we could do that, just have it not be double the
Yeah.
normal inflation rate, but just be, grow at 2 to 3% a year. That's still not great because healthcare is so expensive already. But that, combined with the dynamic economy that we have, the economic growth, the income growth we have in Texas, that could allow healthcare to become more affordable. The actual absolute price would still be growing, but if people's disposable income grows faster,
Yeah.
then in that way, healthcare could become, on a relative basis, more affordable. So I think, to me, that'd be the thing that I think that's a realistic best case scenario. But obviously, what my real hope is that we can find some of these end-arounds or workarounds that allow healthcare to get even that much less expensive, like some of the ones I was talking about earlier.
Yeah.
We asked at the beginning of the show, how did we get here, right? And we got here. This 50% increase over a decade is every year we saw 10% increases. And as Avik notes, that's way above what our inflationary rate is.
Yep.
There's this incredible chart. It's called the Chart of the Century. Every policy wonk uses this in their slide deck on it. But it shows how much faster hospital services and medical services have grown compared to inflation, compared to wages, and especially compared to consumer electronics and cars. And it's incredible. They are just absolute outliers. We don't need to get this perfect to see massive improvement. If we just curb the growth to the rate of inflation, things will be much better in 10 years than they are now for precisely those reasons. So I would say, step one, stop the bleeding.
Yeah. Well, gentlemen, thank you both so much. I really appreciate you taking the time. It's been a pleasure speaking with both of you. So this is the Future of Texas series on Texas Talks, and this is about the decisions Texas makes between now and 2036, the choices that will define what kind of state we hand to the next generation. Healthcare is one of them, and it shapes wages, it shapes who can start businesses, and it shapes whether a teacher in a small town can afford to stay. What I heard today, the tools exist, the political moment is real, and Texas has already proven it can lead. The question is, what do we do with this window? Avik Roy, Charles Miller, thank you both. I'm Brad Swale. This is the Future of Texas, and we'll see you next time.
Thanks, Brad.
Appreciate it.